Hello, my name is Thorsten Steiner. I'm professor of neurology at Klinikum Frankfurt Höchst and Heidelberg University Hospital. It's my great pleasure to perform this interview together with my two colleagues. First, Professor Jan Purrucker, who is a professor of neurology at Heidelberg University Hospital, and Professor David Seiffge, professor of neurology at Bern University. Jan and David, thank you very much for this very interesting study. Jan, question to you. What is the background of your research?
Yeah, thank you very much, Professor Steiner, for this interesting and very important question. In our daily clinical practice, we have seen that we face a lot of patients who have received oral anticoagulation, many of them who have atrial fibrillation, but a lot of other indications as well, and they suffer from ischemic stroke. So they usually are eligible for a medical reperfusion therapy, but due to the oral anticoagulation, they aren't, because of quite strict guideline recommendations at the moment. For example, the Europeans do not recommend to perform a medical reperfusion therapy with alteplase if the patient has taken oral anticoagulation with a DOAC within the last 48 hours, if you're not able to make a specific coagulation test. And we see quite a lot of hospitals who are not able to have these tests. So we also have seen this when we analyzed our patients in our real world data. We have seen dramatically lower rates of intravenous thrombolysis in these patients. So this is a daily clinical problem. Yeah, that's the driver for we had to perform our study.
Thanks, Jan. So how would you then phrase your research question?
Yeah, the question behind all this is behind this very restrictive guideline recommendations, the fear of an increased risk of symptomatic intracerebral hemorrhage in patients who are pre-treated with an oral anticoagulation with a DOAC. But we are not sure if it really is associated with an increased risk if you thrombolyze a patient who had received a DOAC therapy or is under sufficient or an oral anticoagulation therapy. So the main question was really to generate data to see if there's really an increased symptomatic intracerebral hemorrhage risk compared to control patients or not.
Mm-hmm. Thanks, Jan. David, question for you. So how did you do your research? What did you do?
Yeah, so what we did is we performed an international multi-center retrospective cohort study. We identified potential centers by a systematic review and then invited them to join our collaboration. And we collected data of patients who received intravenous thrombolysis who were on prior DOAC therapy with a confirmed intake within 48 hours or unknown last intake. And we compared them with a cohort of patients who received intravenous thrombolysis for ischemic stroke, but who were not on prior DOAC therapy. And our primary outcome was symptomatic intracerebral hemorrhage at 24 hours. And the secondary outcome was functional outcome at 3 months, modified ranking scale score.
Okay, very interesting. So what were the results?
So we managed to enroll more than 20,000 patients, of whom 832 were on prior DOAC treatment. The overall rate of symptomatic hemorrhage was 4.5%, with a numerically lower rate of 2.5% in patients on DOAC therapy. There were many differences in baseline characteristics. For example, patients on DOAC therapy were older, had more severe strokes, and after adjusting for these confounders, the odds ratio for symptomatic hemorrhage was 0.5, which was statistically significant. We then also analyzed different selection criteria because centers perform IV thrombolysis based on different approaches, including DOAC measurements prior to thrombolysis, DOAC reversal, or thrombolysis without reversal therapy nor DOAC level measurement. And we found that in all of these selection criteria approaches actually resulted in the same, more or less safe outcomes. For functional outcome, the result was more or less neutral, meaning that there was no difference, not worse, not better outcome in patients on DOAC therapy, meaning that patients on DOAC therapy seem also to benefit from intravenous thrombolysis.
Very interesting and important. Jan, what do the results mean for our daily routine or practice?
The question is whether we are so confident in these data that we would change our daily clinical practice now. I mean, we have this data. We have also now data from a large, huge study done with the guidelines stroke hospitals in the US, showing exactly the same, although they included the DOAC patients with a more wider window to include once they have taken the last DOAC. So, but we have now two huge cohorts, international cohorts, and so I think we can be quite confident also. I mean, we also have some prospective studies which hopefully will provide some more detailed insight into a comparison between patients who have taken, for example, vitamin K antagonists, oral anticoagulation, or no anticoagulation. Although the groups will be surely smaller, but I think then we will have 3 huge and important cohorts in the next future, and that can, of course, change guidelines and change also our daily clinical practice.
Mm-hmm. So in your study, patients who had a level of the DOAC measured before thrombolysis, were they all receiving intravenous thrombolysis only if they were below a certain threshold?
Yeah, we had different selection methods analyzed, because we had patients from all over the world. We had different selection approaches. For example, the Asians or Japanese patients who had a more liberal guideline already, many of them received thrombolysis therapy despite having a DOAC, and they were not taking the levels like we did in Switzerland, for example, or in Germany. But we also looked on these on the cohorts where we had levels and looked on them, and we were not seeing any safety result there.
We performed several sensitivity and sub-analysis to explain or to further expand on these results. And actually also patients where we had plasma levels available, where you could measure activity of the drug in the blood, or patients with a confirmed intake within the last 12 hours, there was no sign of harm if they received thrombolytic therapy. Because as Jan mentioned, centers who measure plasma levels actually use different thresholds to thrombolyze patients. There are some centers which are very prudent, which say if the threshold is below 30 nanograms per mil, we thrombolyze. For example, we in most centers in Switzerland use a 100 nanograms per milliliter threshold. But even if we could measure any DOAC activity in the blood, there was no sign of harm.
I think this is a very important information. I'm very much looking forward to see the whole data you will present at ISOC. Many thanks to you both and to your group.
Thank you very much, Professor Steiner.